Can please one person give me a thumbs up? Okay, great. Okay. So tonight I want to talk about a major blind spot in cannabinoid medicine. And basically, these major blind spot are women who are carrying the biggest burden of pain, inflammation, a sleep disorder, and hormonal transition related symptoms. I will address this I will go through this dilemma with Simon Sinek golden circle. We're going to start with why prioritize women, how we should address them, and then what should we basically do, what should we build, and what should we prescribe. So the first question is the big why. Why prioritize women? The short answer is that, as I said, because women carry the heavier burden of pain. When we look at the numbers that who is actually suffering, and we go through like some of the severe conditions like fibromyalgia, we see that fibromyalgia is almost a woman health problem. 80 to 90% of patients are women. 75% of autoimmune diseases are women, like autoimmune diseases like MS and rheuma, but in general, 75% women. When we look at migraine, a woman has 2 to 3 times more prevalence to have a migraine, especially hormonal migraine, cyclical migraine. The same is for IBS. Women have 2.5 times more prevalence of developing IBS. And then when we go further and basically look at the like 3 common condition that people get prescribed for, chronic pain, anxiety disorder, and insomnia, we again see across all these 3 like major conditions, women again are affected more. Woman has generally higher prevalence of chronic pain throughout the lifetime, especially post menopause. Anxiety disorder is 2 times more common in women, and insomnia almost 2 times. And again, all of these 3 conditions are the conditions that most patients are seeking and use medical cannabis for. That has been said. Plus to that, we have woman-exclusive conditions. Endometriosis affects 190 million women, approximately 10% of the reproductive age population. Then we have dysmenorrhea and dyspareunia, which are so often comorbid actually with endometriosis. Dyspareunia is painful period, and dyspareunia is painful intercourse. And we see that period pain is most common in like reproductive ages, early in life. 70 to 90% of women have period pain, and sometimes period pain is so uncomfortable that they cannot do the normal daily stuff. They cannot go to work, they cannot go to a sport. And it has been normalized that period come with pain, and that kind of conversation should be changed in our society, because no severe pain is normal. Severe pain is almost always a message from the body that something is wrong. And then we have sexual pain, which peaks after menopause for obvious reason, and up to 45% of postmenopausal women have actually painful intercourse. Not that they lost their desire or that they lost this willingness to have intimacy. No, the pain is just so uncomfortable that they try not to have. And then we have perimenopausal pain cluster. That's 71 to 81% of perimenopausal women have that. Perimenopause comes with a cluster of symptoms, from joint pain, insomnia, sensitivity to food, everything that you can like imagine come in that perimenopausal years, which sometimes could take long, up to 10 years for some women. Normally is about 4 to 6, but in some cases 8 to 10 years. So 8 to 10 years of suffering. And I need to say that all these conditions, women are actively searching for symptom management strategies because the standard of care is not a standard at all. And the majority of the women who tried cannabinoid-based intervention for these conditions, they reported cannabis as effective or very effective. So I think the why was convincing enough. Now the question is that how are we going to address that? Address these conditions in a basically effective way. Again, the short answer is through sex-specific and hormone-specific endocannabinoid system insights. The picture that you see at the left side is I just modified from a 2025 a scoping review on sex-specific cannabis exposure to basically different genders, exposure to cannabis, and how they react differently. Generally, they reported higher sensitivity to overall dose effect, so women are more sensitive in an equal dose. And then in women, we see more nausea, loss of appetite, and anxiety. So generally, the adverse effect or negative effects is the prevalence is higher. And women get faster dependency despite lower consumption rate and more severe withdrawal symptoms. There is one positive thing that women get a greener deal when it comes to sexual behavior and desire. Cannabis help women to like increase their desire, but for men it cause erectile dysfunction and reduce sexual desire. And that's the part that, as I said, women get a greener deal. And there is one group, they're explicitly researching this and they are promoting cannabinoid-based intervention for female orgasmic disorder. One reason for these changes in subjective effects, of course, is pharmacokinetics, because men and women metabolize drugs in general differently. In case of cannabis, a woman reach higher plasma level of THC, 11-hydroxy THC, which is the more psychoactive metabolite. And also we reach THC and 11-hydroxy metabolite faster. So we reach the peak faster and we have more of it circulated in our body. When it comes to CBD, the same story, higher 7-hydroxy and 7-carboxy metabolite. But the other thing with CBD is that CBD kind of starts to accumulate in adipose tissue in women. And over the time, we have much higher CBD metabolite and CBD levels in our plasma in comparison to men. And it's like some kind of a sustained released mechanism. But the story is much more complex than that. Men and women have completely different endocannabinoid receptor distribution and like signaling function. For example, men they have 41% higher CB1 receptor expression in the brain, but men have 41% higher CB1 receptor expression, but women have more effective signaling. And when it comes to basically the expression and the signaling, we see clear dimorphism, sexual dimorphism in those. And some preclinical studies shows that women rely on CB2 signaling for pain modulation much more than men. For example, if CB2 receptors are blocked or impaired, the effect of pain relieving of THC also decrease. So it's very interesting to pay attention to that CB2 signal. Again, that is preclinical study, but CB2 pathways appear to be much more important for women modulating pain. Then we come to like the second difference. So the first one was receptor distribution and function. The second one is overall endocannabinoid tone. Women have significantly lower endocannabinoid tone, anandamide, 2-AG, OEA, and PEA, which are ethanol amide, also in the endocannabinoid system. And women also have much lower 2-AG levels in the brain pain modulating hub, which is preaqueductal gray. In that region, woman shows like much lower, 2-AG. So if that was not complicated enough, we also now understood that endocannabinoid system actually has a bidirectional feedback loop and bidirectional signaling with sex hormones. This slide that I put here, it's need another webinar by itself, but I just wanted to like put the all hints, give everything here as I can. So when I talk about the relation between endocannabinoid system and sex hormones, particularly estrogen, and that is bidirectional, it means that estrogen directly affect the endocannabinoid tone and signaling efficacy, and the endocannabinoid system also modulates the menstrual cycle. When estrogen goes high in the body, estrogen suppress the FAH enzyme, FAAH, and that causes the anandamide level to get high. So around ovulation, women have much higher sensitivity to THC because the body is like it's in a hypersensitive mode and full of anandamide. Progesterone does the opposite. Progesterone basically push the degrading enzyme of FAAH or FAH enzyme, and that causes the anandamide level to get lower. And also, there is one molecule, pregnenolone, which is the precursor of progesterone, and that is the negative modulator of the CB1 receptor. So if you want to like kind of have a simple explanation for that, when estrogen is high in the body, the endocannabinoid system is more sensitive, and estrogen basically is an amplifier of the endocannabinoid system, and progesterone is the dampener of the whole endocannabinoid system. And besides this, also our ovaries should be counted as an endocannabinoid organ because our follicles also produce anandamide, and which is like very, very important for egg maturation, and also throughout the whole reproductive tract. We have all the whole endocannabinoid system is involved in the health and maintenance of every big and a small process in reproductive tract. And we know that in 2018, Di Mazzo explained the endocannabinoid system as a system that helps us eat, sleep, forget, protect, and relax. But something that he needed to add to these five parts is also menstrual cycle. So endocannabinoid system in female body not only help us eat, sleep, forget, protect, and relax, but also regulate the menstrual cycle. And that become very, very important across the, I have to be mindful of time. It's okay, we still have time. When it comes to all these hormonal changes across the woman lifespan, in reproductive years, we just said how interconnected endocannabinoid system and sex hormones are. So when we look at the reproductive years, the endocannabinoid system tone and responsivity changes in a predictive way. So around ovulation, when the estrogen is high, we have a more sensitive body to THC, and actually all of the positive effects of anandamide, which is pain modulation, better mood, like having better energy, we see that women around ovulation, like they also like in animal models, human models, our pain sensitivity gets much higher, like we can tolerate more pain, our mood is better, and it's all because of the effect of estrogen on the endocannabinoid system and the level of anandamide. But when we come to like mid-luteal phase, which progesterone is the highest, our body lose that buffer of anandamide, and that is why our body is like sensitive to more negative effect of THC. I'm gonna talk about it later, but just that you know that throughout the menstrual cycle, one dosage may not work the same. And then when we come to perimenopause, so that was good for reproductive years. We know that everything changes, but at least everything change in a predictive way. But when we come to perimenopause years, it's a zone of chaos. We know that like the trend of estrogen is decline, but it's not decline in a linear way. The decline is unpredictable up and downs. Sometimes the level of estrogen in perimenopause can be 4 times more than the level of estrogen in reproductive years. And you can imagine here we have a chaotic and unpredictable system which can unpredictably respond to therapy. So some medication and some dosage that worked last week might not be helpful next week. So that's need a lot of compassion from health givers and health takers to like help women pass this phase. And then post-menopause, we have a sustained lower endocannabinoid system function, tone, and also signaling, like CB1 receptor density and signaling in cortex decreased by 10% per decade. And again, like generally, we have also much lower endocannabinoid tone across all the like anandamide, 2-AG, OEA, PEA, all of those like ethanol amide involved. And now, when we like with all of that information in mind, and when we when we try to connect the dots, we understand, yeah, okay, interesting. Probably that's the reason that is like this endocannabinoid system dysregulation could be one of the underlying mechanism of many women health diseases like endocannabinoid system, like endometriosis, PMDD, IBS, migraine, fibromyalgia, especially perimenopause symptoms. I come to this also a little bit later because it's very interesting. It's very interesting that sometimes women are diagnosed with fibromyalgia, and the fibromyalgia onset or worsening the symptom is parallel to perimenopause years, which actually fibromyalgia could be a misdiagnosis to musculoskeletal syndrome of menopause. That's all, they are all very interconnected. And we rarely see that each of these like conditions or symptoms have a specific cluster. They come together. Many of the endometriosis patients, they have IBS. Many of the migraine patients, they have IBS. Fibromyalgia patients have a higher rate of reporting, like again, IBS and migraine. So they are all interconnected. And beside that, we have all of these other conditions that we see positive signals, like patient signals, surveys, and also preclinical studies from menopause, insomnia, vulvodynia, breast cancer. And they also may have some underlying mechanism that in the future, we can connect all the dots together. So and basically, that is the whole, the targeting the endocannabinoid system can be one of the, if not revolutionizing, can significantly improve the standard of care when we talk about different women health conditions. So now that we know all of that, what shall we do with this like simple complexity? What should we build? And the short answer is that we have to build hormone-aware dosing and formulations for female physiology. I'm gonna start with THC and where to be careful with THC because that is, as I just mentioned, sorry, a minute, endocannabinoid system modulates and basically is a gatekeeper of the menstrual cycle. And we just said that endocannabinoid system is involved in pregnancy from A to Z. Actually, from egg maturation to implantation and then embryo development and delivery. So in reproductive ages, no or low THC protocols should be the first line had first like hint or first advice. And what we should also be aware here is about cycle aware dosing and education, because again, the same protocol, the same dosage might act or respond differently throughout the menstrual cycle, especially for conditions like PMDD and anxiety, because generally when we go toward the luteal phase, end of luteal phase, women are more anxious. So high THC product in that phase can cause paranoia and much severe anxiety. So that is what should we have in mind about THC. Also, like in addition to that, we know that actually THC cause menstrual cycle irregularities. We have with chronic THC use, we have shortened luteal phase, and we also have 38% more unovulatory cycles in comparison to non-THC users. And when we like change the life, when we like move the life stage from reproductive age to perimenopause, here pivot should be the golden standard. Like again, the product, the formulation, the dosage that worked 2 weeks ago maybe won't work this week. And a lot of women here, they felt this desperate. First of all, they think, okay, the medication is not working or the quality of the medication of the supplement change. It's really not like that. And here, like we can have more THC, but the important thing is that using the THC more in the evening, because one of the unsettling symptoms of perimenopause is brain fog. And brain fog happen because the lower estrogen and progesterone interact with acetylcholine signalings and choline journey, sorry, signaling, you know what I mean. And actually, what we know that THC also dampen the acetylcholic signaling. And because of that, THC during the daytime actually can put the oil in the fire of brain fog. That is why it's better if a woman really needs THC, especially when they have like fibromyalgia, the dosage should be in the evening. And then in postmenopause, we have it's the best. We can definitely have like more THC in the prescription. And it is interesting to know that although we talked about it, that endocannabinoid tone and endocannabinoid signaling baseline come lower, but older people have higher responsivity to cannabinoid medications. And that was a very, very interesting study in 2026, which they like compared younger people and older people. And after 1 hour of cannabis inhalation and 2 hours of taking edibles, they clearly could see that older population have more anandamide in their blood. So the rationale behind it was that like probably we get more responsive to exogenous cannabinoids as a compensatory mechanism. So, okay. And as I said, clinical principle here for women is that is not to start low and go slow, start lower and go slower because of the metabolite. We have a stronger metabolite and we have higher adverse effect. And again, these lipophilic compounds, THC and CBD, they that they get stored in adipose tissues and they have a sustained release. So, like very be patient and slow with dosing. Uh, like as a case symptom, I brought fibromyalgia here because actually fibromyalgia is again is a very confusing very confusing disease. A lot of time you cannot really say if it's really fibromyalgia or if it's the onset of perimenopause symptoms because they are very parallel, that they have a lot of like similarities. What here we could see is that, and the reason why cannabinoids help a lot is that in patients with fibromyalgia, we see altered circulating endocannabinoids. And we also, like we said before, that the change in estrogen and progesterone level also altered the circulation of the endocannabinoids. In fibromyalgia, we also have the altered CB1 and CB2 signaling, and we see in preclinical and clinical trials that enhancing endocannabinoid system tone with different antagonists could really improve fibromyalgia-like pain. But what is very interesting in case of fibromyalgia is that actually CBD alone is not very helpful in this case. And THC is the cannabinoid that carry the effectiveness of the cannabinoid intervention. I put here a new like clinical study, observational, it's not observational, it's a randomized controlled trial from Israel, which they give a woman 12 to 13 milligram THC sublingually, and it significantly reduced the spontaneous fibromyalgia pain. The dosing was similar to older studies on doronabinol, and here they had like the extract that they use or the sublingual formulation that they use was had like a very minor amount also of CBD. And then there was a like 2024 systematic review of 19 different studies, like observationals, clinical trials, and also systematic reviews. And it was around like I cannot remember how many patients was that. Was probably like over 1,000 patients. I cannot remember. But also in this study, they showed that THC and CBD balance or THC dominant products show greater efficacy than CBD alone. And one a randomized controlled trial in last year, that was CBD alone. Dosage was very low, 50 milligram, but it was over 24 weeks. And actually, when the study was over, they didn't see any difference between placebo and CBD group. So that was basically all of the studies hint toward like at least having a THC in the formulation is the guarantee of the efficacy for this condition. So now the question is that what products are actually relevant? In reproductive age, of course, CBD dominant are relevant. We talked about it enough. And but also like now women that they need THC for like anxiety and endometriosis pain or chronic pain, they use very microdose amount of THC, which is it's become very much popular around like women in general. We come to that also later, but like very low amount, like 2 to 5 milligram THC is could be very helpful, but if a THC is needed. And like in perimenopause, balance and a mixture of THC and CBD can become relevant because perimenopausal women also show much higher anxiety and depression than postmenopausal and women in reproductive age. So again, we should always see the risk and benefit of adding THC. And then, for postmenopause, we can definitely like that they tolerate THC much better. What we can really think of, I mean, unfortunately, in Germany, we cannot do that, but I know that in Australia, like pharmacies can work a lot, like in compounding formulation with minor cannabinoids. So, for example, in perimenopause years, CBG is getting a lot of attention. There is one upcoming clinical trial on CBG, and what they want to measure is anxiety and also cognitive performance. Because last year, or it was 2 years ago, Ethan Russo did a study and they showed that actually 20 milligrams CBG not only significantly reduced the anxiety, but increased verbal memory. And verbal memory is something that perimenopausal women really have to deal with. I'm one of them. Mid-sentence, I cannot remember what I wanted to say. Even in Persian, that's my mother language. It's very disturbing. So CBG is one of the minors that get a lot of attention on that front, and also addressing and activating CB2 receptors, because CB2 receptors they have a strong relatability and a strong mechanism of action when it comes to osteoporosis, and activating that theoretically and preclinically could help with bone loss later in postmenopause. One of the minor cannabinoids that could be very interesting in postmenopause is CBN, obviously for sleep, because postmenopausal women, the condition that they are really suffering from is insomnia. And also, again, that's the case not in Germany, but CBC could also be very, very effective in combination with CBD for addressing pain. And we have different route of administrations that could be that women are really looking forward to have based on all the surveys, which are lozenges. Like lozenges, I get a lot of positive feedback of the efficacy. Topicals for joint pain, rheuma, and local pelvic and vulvar pain. Also vaginal and rectal suppositories and vaginal cremogels. They are the newest frontier. And again, there are some good clinical trials, especially in a new one on vaginal cremogel for vulvodynia, which shows significant results. For here, I brought endometriosis as a sample case condition, because for endometriosis we have the strongest biological rationale for suppository and intervaginal application. We know that in endometriosis we also have this altered endocannabinoid system tone, and we know that severity of the endometriosis symptom change in the menstrual cycle. Most of the women have much higher pain before, premenstrually, before their menstruation starts. Again, it's a good correlation between the effect of hormones on the endocannabinoid system and the pain modulation signaling. But beside that, the local lesions microenvironment of the endometriosis, they showed altered endocannabinoids. So the expression of the receptors is altered, CB1 and CB2 receptor, and also in ectopic lesions of endometriosis, we have much higher TRPV1 receptor expression, which is the nociceptive one, and that's one of the underlying mechanism that why these lesions are so painful. So with all of that alteration in signaling level, in receptor level, it's like that in endometriosis, the endogenous endocannabinoid pain breaking is weakened. That is why that's the reason why vaginal suppositories and vaginal application could be an add-on therapy into the either oral or inhalative application forms. From endometriosis, from over the world, all the basically surveys, all the observational studies, 100% of women who used cannabinoid-based therapy like THC, CBD combined, they report significant improvements, not only in pain, but also in the quality of life. The latest study that I put here is just like published a couple of months ago from New Zealand. And the intervention was CBD oil, and in suddenly the pain break times, women could also use inhalative form of CBD THC flowers. The results show significant improvements in all domains of EHP 30 questionnaire, which is the standard questionnaire for endometriosis. And these different conditions, these different aspects was pain, emotional well-being, social support, self-image, and so on and so forth. And again, as I said, all of the evidences suggest that uh, cannabinoid-based interventions is like it's the best available option for address endometriosis pain, because the pain mechanism is very, very complex. So um, we talked about vaginal suppositories, so that is something that I wanted to definitely bring up, because it is we know that at the moment, like there are many products on the market that claim that they have like some vaginal suppositories, and there are also like many Instagram and YouTube recipes on vaginal suppositories with cannabinoids. But there are very important stuff to think of. First of all, is that fat traps the drug, but most of the vaginal suppositories that we have, they are fat based. So the partition coefficient of lipophilic compounds like THC and CBD is 6 or 7, and they don't want to lose fat. So at the end of the day, we only have 20 to 38% release from the fat when it's come to vaginal area, and the diffusion to a watery mucus layer is so low. So we definitely need some penetration enhancers to put in the formulation. We also know that different fats release these endocannabinoids differently. For example, cocoa butter is better for releasing, it has a higher release of CBD, but Vetaspol H50 has a better release of THC. So the mixture of these two would be optimal for having a better suppository. Also, the other thing is that more drug is definitely not more release, because like that there was an experiment that they see that they compared 0.3 gram to 0.6 gram THC in suppository, although the second one, the 0.6, has double the amount of the 0.3 gram, the release was less than the 0.3 milligram THC. So, and that's because of the viscosity. We have to be very careful that very careful how much drug load we have on the suppositories, and the best is always less than 10%. And then, like the last one is a very shocking fact, that whatever we know at the moment at pharmacokinetic studies is actually rectal. There is not even one study to measure the pharmacokinetic of vaginal suppositories when it's come to cannabinoids. And I know many companies now claiming that they have vaginal suppositories. I'm very willing to see their PICA study. But there are I know that there are 3 ongoing clinical trials now in US, Australia, and Italy. And the PK study is at least a part of their clinical trial design. Okay. So I have a little bit of bonus material here, market signals. I know we have like 2 minutes left, so I try to go through them very short, very fast, so we have time for a question and answer. Uh, all of these like market signs is we talked all about these different application forms, where can they be used, why they can be used, but from the other side, like we heard what the science is saying, but we also now a little bit pay attention to what market is saying. So data from US and Canada is showing that women are actively moving away from smoking. They want discreet, smoke-free, and odor-free consumption methods. And also, a lot of like market research data shows that edible market is basically exploding, and like especially low dose edibles. I told you like microdosing is now become mainstream, and it's one of the drivers of the whole edible market. And edibles and this microdosing are driven by wellness seeker target group and population, obviously. And one interesting is that cannabis microdosing is the most prevalent microdosing about in US adult, 3 times more than psilocybin microdosing. So that is something that it's good to pay attention to. Vaginal and mucosal route is emerging for especially for like menopausal and perimenopausal women. In one survey, 78% of menopausal cannabis user expressed the interest in exploring cannabis-based vaginal product. And one of the reasons is, of course, as I said at the beginning, is genitourinary symptoms of perimenopause and menopause, vaginal atrophy, dryness, and dyspareunia. So women are already here. The industry, unfortunately, isn't. In 2023, for the first time ever, US women, like young US women, surpassed men, also surpassed men at the same age in daily and nearly daily cannabis consumption. The trend is happening in US, but I'm sure that some year later it's going to also happen in Europe. Women in US now account for 42% of all cannabis purchases, which was only it's like almost a 10% raise from 2020. In New York dispensaries, women are outspending men per visit, $91 to $89, which again shows that midlife and older women, generally women, are one of the fastest growing cannabis consumers segment in US. Also in Germany, the official statistic from Begleiterhebung was that 51% of prescribed patients are actually women. And again, the question is that why actually clinicians, companies, investors are not paying attention, and why patients are not like asking for more. So to the clinicians here, please, like sex-informed protocols and prescribing frameworks can significantly improve the therapy adherence and therapy efficacy. Like for the companies, product design and R&D strategies for women. If you are here for only philanthropic reason or for money or both, women are your target group. For investor, the same. We should identify vital space in female market, which is like huge. We already saw all of those conditions that could be addressed, and it was not basically all of that. It was a glimpse of it. And to patients and curious individuals, what I really want you to take is that your job is to know your option exists and ask for it. It's the job of the companies and clinicians and all the other people in the cannabis industry to make them for you. Because when you ask, when the demand is there, the market gonna react to what you need. So I'm gonna now finish it now with this like post that I had a couple of days ago in LinkedIn. Girl just wanna have options formulated for her biology, not his. And by that, thank you so much. So here are my contact details, and I have a newsletter for perimenopause women. Actually, the name is Recalibration, that is in Substack. If you want, I talk about this topic, but particularly like perimenopause transition, which I find myself